Honorable Secretary, Dr. Rajasi Sengupta ma'am, eminent speakers of today's session, Dr. Chaitanya Shembekar'S sir and Dr. Pundambekar sir, he is yet to join us, respected chairpersons and all the DGIs. It gives me immense pleasure, pride and happiness to welcome you all to our 51st session of DGOGAN. Last 10 months, DGOGAN has witnessed the humongous knowledge shared by eminent faculties, and we all have learned and congregated it all. It was only possible because of the efforts put in by our President, Dr. Vaidehi Marathe Madam, supported by our Honorable Secretary, Dr. Rajasi Sengupta ma'am, and Team NOGS to get in the best of the faculties and learn a lot of things. All the participants, the DGIs, pan-India and overseas, have always supported and participated in our sessions, and your presence have truly helped us to do better. जुम्मे की जुम्मे मिलना एक आदत सी हो गई थी. I can definitely tell about something about DGOGAN like this, because we almost had every Friday we had this session of DGOGAN. And today on this, when we started on 4th of April 2020, and over this last 10 months, today on the 51st session, the landmark session, we have an academic celebrations. This, along with the stalwarts, the eminent speakers, that is Dr. Chaitanya Shembekar'S sir and Dr. Shailesh Pundambekar sir. So, and today's this academic celebration is supported by the Inca Life Sciences, a Sun Pharma division, who are the makers of Letrozole, Normos, and Ovaris Plus. So thank you very much, Sun Pharma, Inca Life Sciences, for supporting our today's session. And now let's begin the session with the welcome of President Dr. Vaidehi Marathe Madam. Over to you, ma'am.
Thank you so much, Swati. Hello and good afternoon. Respected faculty of the day, Dr. Shailesh Pundambekar sir, Dr. Chaitanya Shembekar, family members of Dr. Kumud Tamaskar, Dr. Vijay Tamaskar and Dr. Manisha Tamaskar, and her grandchildren, Dr. Amog and Dr. Nishad. Chairpersons of the day, Dr. Kundan Ningre sir, Dr. Sadhana Patwardhan, Dr. Bhute ma'am, and Dr. Yamini. Respected seniors, boys and girls, I welcome you all to the VR world, the Vaidehi Rajasi's virtual to reality world, the unique digital space where we present a weekly extravagant bonanza of academic and non-academic feasts. Friends, during this entire year of the pandemic, NOGS has been the only society to conduct these standalone ongoing CMEs week after week, right from the beginning of our tenure till almost the end of it, with very practical, clinically important basic topics, which is the USP of our CMEs. And that is why we had named them DGOGAN. And now we are marching towards the end of this series as we wind up our stupendous tenure in March. But we have some excellent events lined up for the next 2 months, and we all look forward to seeing you there. Coming up very soon from 11th of February, we have this ICOX Certified International Ultrasound Certification course. End of the month, we have the very popular PG4s, where PGs from Nagpur and all around Nagpur will be attending a physical conference with very interesting sessions for them. Coming up in the first week of March, we have the entire week International Women's Day celebration, all spread through the week. And the second weekend would see our most awaited, the glittering annual conference, the Gynecon. Along with that, we have planned the NOGS pageant, that is the Miss and Mr. NOGS. So many glittering events are planned for the last fag end of our tenure. Today, as you all know, DGOGANs have been conducted in 3 modules, and all of them have been super successful till now. And today we have fortunate to have 2 stalwarts of the field with 2 amazing presentations. We are very proud to host the prestigious Dr. Kumud Tamaskar Oration today. to be delivered by our own Dr. Chaitanya Shembekar, the charismatic infertility consultant, currently the AMOGS Infertility Committee chairperson, and our Nagpur Obstetric Gynec Society past president. We both, me and Chaitanya, go a long way together as batchmates as way back in 1986. And I feel so proud that Dr. Chaitanya has made it so big in this field. Thanks, Dr. Chaitanya, for accepting our invitation, and I'm
Thank
sure
you very much.
you will do full justice to the stature of this oration.
Thank you very much.
Second session, we are very fortunate to have someone who stands tall in the field of laparoscopy, someone people look up to, someone every doctor respects for the phenomenal work done by him. Yes, Dr. Shailesh Puntambekar. It's like a dream come true for us. He's a very distinguished speaker, a name to reckon with in this field, a teacher par excellence. Thank you, sir, for accepting our invitation. I'm sure everyone present here is dying to listen to him, to learn the fine art of laparoscopy. Last week, he couldn't join in because of some complicated surgery, and we are very, very hopeful that he will make it today in spite of his very busy schedule. Without much ado, I welcome both the speakers, the family of Dr. Kumud Tamaskar, and I thank them profusely for accepting our invitation. Dear doctors, welcome back to this action-packed virtual learning platform yet again. Together, let's member of Maharashtra ESAR, and it has always been a pleasure to work with Chaitanya for this, and we have organized and executed 3 successful conferences at Nagpur, and this has been possible, Chaitanya, because of even your hard work and contribution. Every time you were always there with me. He's a member of the Infertility, Endocrinology and Endoscopy Committee of FOXI. He is the recipient of Kamini Rao Yuva FOXI Oration Award. He's been a gold medalist at undergraduate level. He has given orations and talks in more than 50 FOXI societies. Not only this, he is a faculty in the national level conferences, and he has published articles in various journals and presented papers. So over to you, Chaitanya, for your oration. I also give my respects and regards to late Dr. Tamaskar Madam, who has been a legend for the city of Nagpur. Her untiring, her dynamic approach towards the practice of infertility. You know what I keep on hearing from our seniors, she was so dynamic and she was an achiever, you know. She wanted to bring infertility to Nagpur. She wanted to bring endoscopy to Nagpur. So she is a legend, and I pay my homage, regards and respect to Tamaskar Madam also. And I acknowledge the presence of Manisha, Vijay, Amok and Nishad from the family. So over to you, Chaitanya.
Thank you, Dr. Sadhna. Thank you, Kundan, chairpersons, for today's oration. I bring greetings from Omega Hospital along with my directors and consultants. I must thank Dr. Vaidehi Marathe and Dr. Rajesh Sengupta for giving me this honor. Presenting Dr. Kumud Tamaskar oration is indeed a great honor for me, and I am really humbled. I have witnessed the aura of Dr. Kumud Tamaskar during my childhood. During that time, those times, and even today, Tamaskar Hospital was a landmark in Dhantoli and Ramdaspet area. And while I was studying in IGMC, people used to talk about her surgical skills and clinical acumen. She was the one who for the first time started IVF and fertility clinic in Nagpur. And I am grateful to Dr. Vijay, Dr. Manisha Tamaskar, Amog and Nishad for this gesture. And sharing the stage with none other than Dr. Shailesh Puntambekar is, I think, an icing on cake. And I'm also thankful to Dr. Madhuri Patil and Dr. Rajesh Koradia because they have given me some inputs for this presentation. Thank you very much. So I'll start with today's oration, and that is declining fertility, today's challenge. If you look at the changing trends in the fertility, the incidence of the rising fertility and the problem associated with fertility, you will find that the most important thing which you find is the grandparents, our grandparents, they used to have many kids, and my grandparents were having 8 children. Then today's generation is actually a generation of either a single kid or double income, no kid. And if you look at the average children per woman, it has gone down to 1.61. And if you look at this Lancet publication, it says that it will go far below this in 2100. And almost around 10 countries even today have very low fertility rate of 1.3 or even lower. So if you look at the mean age of conception, initially it was 20 to 25 years, and now it has become almost 30 years. And since last 2 decades, you'll find that it has increased by 4 years. And the mean age has gone above 30 in some developed countries like Denmark, Finland, Italy, and Netherlands. And even in India, you can see that elite class, they postpone their pregnancy beyond 30 years. And you have to note here one point, that fertility starts declining rapidly after 32 years and it goes sharply down after 35 years of age. And that is the reason why you need to have counseling and awareness in the society that this is a problem which you must understand. Now, there are many reasons for declining fertility. There are social causes, some behavioral changes in the couple, which are really complex and difficult to understand. And then there are living standard, educational standards, and other things which has added to this. And that is the reason why fertility is declining. There is a study in Namibia gone to 90% fall in fertility rate because with educational level, the fertility is declining, and that is very obvious. Now, if you look at the male infertility, we'll start with the male infertility. This is rising. And I remember in my college days, we were taught that the incidence of male infertility is 30%. And now it has gone to almost 60%. And declining fertility in men is actually a big cause of concern for all of us. And it is really alarming. So you can see almost every other patient of IVF is having male problem. The female partner problem may or may not be there, but male partner problem is almost there. So the question is, where have all the cowboys gone? And I think we need to answer this question. This is a serious question. This is the article which has appeared in Gulf News, and one of my friends he shared this with me, and it says that sperm drop could make humans extinct. And this actually started happening in Scandinavian countries. It has been found that the semen quality is going down and the count is dramatically falling. Initially it was 100 million plus, and now most of them, even today in our day-to-day practice, we don't find many patients or many husbands with semen count of more than 100 million. Most of them, they are male partners, they are having semen count around 20, 25, 30 million. We are happy. That is the problem. So quality and count both are falling down. And this is because of so many reasons. I think lifestyle factors, they play an important role. Stress, advanced age, caffeine consumption, obesity, tobacco, heavy alcohol use, and recreational drugs. Along with that, environmental factors like the pollution, heavy metals, pesticides, all these things are adding fuel to the fire. Obesity is, I think, something which is a cause of concern. And with obesity, there is a reduction in the androgen levels, high A2 levels, and increase in the scrotal temperature. It has been noted that for every 5-unit rise in the BMI, there is 2.4% fall in the sperm count and 2% fall in the sperm volume. So that is the problem with the obesity. Even too thin patients can also have problem of sperm count because they can have some problems like thyrotoxicosis or some other endocrinological abnormalities. Now, if you look at the age and fertility, there is advantage to the boys. It is said that why should boys have all the fun? But I think the answer is it is the nature's wish. And for boys, age is just a number. If you look at the history, you'll find that Charlie Chaplin fathered a child at the age of 73. But boys, don't get so excited. Take it with a pinch of salt. Because even in boys, it has been found that after 35 years of age, DNA fragmentation goes on rising. And after 40 years of age, there are genetic mutations which are very common. And after 50 years of age, Down syndromes, neurofibromatosis, autism, and Klinefelter syndromes are commonly seen in men. And there is a relation of male factor and cancer. And this is something which is a cause of worry because cancer, the rate incidence is rising so much that not only testicular cancer, but other cancers like melanoma, prostatic cancers, non-Hodgkin's lymphoma, and even thyroid cancers and lymphoblastic leukemia all are associated with male infertility and male factor infertility. It is said that nothing succeeds like normal semen analysis. And if you belong to a elite 100 million club, then there should be absolutely no problem. But I think it is not so. We all know the WHO criteria for semen analysis. We need not discuss this. But whenever we talk of declining fertility in men, we have to go beyond this semen analysis, and you have to think of sperm function test, and also you have to think of psychological factors, which are also equally important. So this is the study which says that impaired semen parameters alone cannot be used to predict fertility, as these men still have a chance of being fertile, except when a man has azoospermia, necrozoospermia, or globospermia. So husband semen analysis, either it is normal or it is abnormal. In both the situations, you have to go beyond semen analysis and do semen function test. So this sperm function test is something which you all should know. And we should know that there are so many sperm function tests which are available, like Hoss test, anti-sperm antibodies, teratozoospermia index, CASA, etc. But the DNA fragmentation test has become the most popular test. And we do this because this normal semen analysis report does not give semen DNA fragmentation report. Now, as far as erectile dysfunction is concerned, erection is something which has got a coordination of psychological, neurological, endocrinological, vascular, and cavernous factors. And it is becoming so common that sometimes you may have to ask leading question to the patient, and you may have to take help of sexologist, psychiatrist, and sometimes you may have to go for sperm retrieval techniques like ejaculators and vibrators to get the semen collection in difficult situations. Now, the commonest problem which is associated with male factor is idiopathic oligospermia. It is called as oligoasthenoteratozoospermia syndrome, which may be mild if it is 10 to 15 million count, moderate if it is 5 to 10 million count, and severe if the sperm count is less than 5 million. Now, before labeling a case as a case of idiopathic oligospermia, you have to look after the pretesticular, testicular, and post-testicular causes like HPO problem, central causes, varicose or hydrocele, or post-testicular causes like urethral inflammation. And after ruling out these causes, you can label a case as a case of idiopathic oligozoospermia. And in this situation, micronutrients and antioxidants, they do work. Astaxanthin, lycopene, CoQ10, L-carnitine, and zinc and vitamin folic acid combination can be given. And studies say that it improves the semen parameters in azoospermic patients as well with maturation errors. And that is the reason why we are planning PESA, or let's say we give this antioxidants to the patients. But if you look at the Cochrane database, it is said that only there are few studies, only 4 small RCTs which say that antioxidants are helpful, and therefore the evidence is lacking, and therefore you need more studies to say that antioxidants can actually help in male infertility. Now, the most important thing in male factor, this is the last part of my male factor causes of declining fertility, is how to decide about the right choice of the treatment. And treatment is to be decided by depending on various factors. And I think all these factors are so important, and these are basically all sperm function tests or semen function tests. And you all can take a screenshot of this slide, because this slide is going to help you in deciding the line of management in the patients of male infertility. Like suppose the concentration is more than 10 million, you can think of IUI, but if it is less than 10 million, you have to think of IVF. But if it is less than 1 million, go for ICSI. Total motile sperm count is something which is becoming more important nowadays. And if it is more than 5 million, IUI, 1 to 5 million is IVF, and less than 1 million is ICSI. TZI, teratozoospermia index, less than 1.6 is considered as normal. But if it is more than 1.84, then you have to go for ICSI. Similarly, Hoss test, more than 60% vitality is considered as good. But if it is less than 50%, you have to go for ICSI. And the most important thing is sperm DNA fragmentation index, which if less than 15%, you may think of IUI. If 15 to 30% IVF, but more than 30%, then you have to go for ICSI. And you may have to go for TESA ICSI if it is more than 60%. Now comes the female factors. And if you look at the declining fertility in females, there are various things which are associated with this. These include premature ovarian insufficiency, where FSH is more than 25 and MH is very low. It is actually a hypergonadotrophic hypogonadism. But then there is a more common situation, that is diminished ovarian reserve, where FSH is high and AMH is low, but ovaries are still working and delivering to their fullest potential. And then there is one more situation, that is hypogonadotrophic hypogonadism, where FSH is low and AMH may be normal. Now, the premature ovarian insufficiency, initially they used to call it premature ovarian failure or premature menopause, but it was Albright who rightly said that it should not be called failure, but it should be called as inefficiency, because failure is sudden and inefficiency is a gradual process. And even STI guidelines say that the term which is used nowadays is premature ovarian insufficiency, which means that the ovaries are not functioning to their level best. How to define POI? POI is a clinical syndrome which is defined by loss of ovarian activity before the age of 40 years. The patient will have either amenorrhea or oligomenorrhea for 4 months. They initially may have short and scanty cycles. FSH levels are more than 25, E2 levels are less than 50 on 2 occasions, at least 1 month apart. Now the incidence and prevalence is rising. Initially it was 1%, now it is 2%. And the question is, can we reduce the prevalence of POI? And the answer is yes. We have to make some efforts to reduce the evidence of incidence of and prevalence of POI. And for this, the most important factor is age factor. It has been found that as the age advances, the chances of POI also increase. And therefore, if you ask the patients to marry early and have conception early, then maybe this problem can be solved. If you are doing surgeries, you have to give tissue respect, because if you give proper tissue respect, then maybe the ovaries will function properly. Lifestyle is important, and this is something which is always there. And if you are treating the patient for malignancies, you have to be extremely careful, because you have to think of the fertility factor as well. Now the causes of POI, most of the cases they are idiopathic, where 90% of cases you don't know the cause. But the other causes include genetic causes like Turner syndrome, trisomy, and Fragile X syndrome, autoimmune disorders like anti-ovarian antibodies, anti-TPO antibodies, infections like or uveitis and tuberculosis, or induced causes like bilateral oophorectomy or bilateral cystectomy, or chemotherapy and radiotherapy. And chemotherapy and radiotherapy is something which is becoming so common nowadays that you have to always think of the ovarian failure after giving this treatment. The patient presents with scanty menses and frequent menses, and then the patient will have amenorrhea. They will have infertility. They will have hot flushes and vaginal dryness and night sweats typical of menopause. They will have skin changes, hair loss. Autoimmune disorder will be seen in the form of goiter, easy fatigability, and anxiety and depression, so typical of menopause. These symptoms are very commonly seen. You have to take proper history, take proper menstrual history. Chronology of events is important. History of early menopause in the mother and family is important. Radiation exposure, chemotherapy history, history of infertility, and recurrent pregnancy loss. Because if the AMH is low, the patient will conceive, but patient will not be able to continue her pregnancy. And easy fatigability. Then you have to examine the patient and confirm the diagnosis. And you have to go for the investigations. We have been taught during our MD days that whenever the patient comes to you with amenorrhea, always do a beta HCG or urine pregnancy test to rule out pregnancy. And this is something which is true even in POI. You have to rule out pregnancy first. Then you do FSH, which is given by STI guidelines. It should be more than 25. AMH levels are not given in STI guidelines as an investigation, but I think they are becoming more and more important nowadays. Karyotyping is something which should be done, and TSH and antibody testing should be done, and of course transvaginal sonography. And you should always do transvaginal sonography unless it is contraindicated. And here you will find that the ovaries are small with a minimum or no intrafollicles, and the endometrium is thin, and there is no vascularity to the endometrium on the Doppler. The management of infertility depends on this situation or the extent of ovarian failure. It is said that once the ovarian failure is established, you just cannot do anything. And the only option left is donor program. And that is the reason why you should catch them young. So catch them young is the mantra for the treatment of premature ovarian insufficiency. There is something called as in vitro activation, where the activation of dormant follicles is done. And these activated follicles are again put in the abdomen through laparoscopy. And this sounds interesting, but I really don't know about this treatment. But there are few publications regarding in vitro activation as a treatment for premature ovarian insufficiency. The next and the most important for all of us is the diminished ovarian reserve, or something called as diminished functional ovarian reserve. This is a term used to determine the capacity of the ovary to provide eggs that are capable of fertilization, resulting in a healthy, successful pregnancy. Now, if you look at the age, you will find that we discussed that after the age of 35 years, the chances of pregnancy declines dramatically. The pregnancy declines dramatically after 35 years of age. But there is something which is more important than a chronological age, and that is a biological age. And biological age and chronological age may not be same. But if you look at the biological aging, you will find that as the ovaries they stop functioning, or there is a diminished ovarian reserve, there is resistance to gonadotropins and there is no stimulation of the follicles, and you have to know the strategies to enhance the efficacy of treatment, which is very important. So we will discuss this, that how to enhance the treatment strategies so that you get good results in patients with diminished ovarian reserve. And to understand this, you must know the physiology. So you look at this diagram, which is actually a very famous diagram, which gives you idea about the ovulation. There are primordial follicles, there are primary follicles, secondary follicles, small anther follicles, and then they become dominant and ultimately ovulate. Now, if you look at this FSH dependence is only for 10 days, but there is something called as gonadotropin independent zone, which is actually under paracrine control. So you have to consider all this, and this is the almost period of more than 70 days. So whenever we are treating the patients, you have to not only think of the FSH dependent zone, but also think of the FSH independent zone, where there are some drugs which act very well, and therefore you have to think of complete ovulation process, which takes almost 70 to 80 days for the ovulation to take place. Now there are various definitions, and initially came the Bologna criteria, and which came in 2011, which says that age more than 40 years, previous poor ovarian response of less than few sets with conventional protocol, and abnormal ovarian reserve testing like AFC 5 to 7 and AMH 0.5 to 1.1. Out of these three criteria, if you have two criteria, then you label the patient as a case of diminished ovarian reserve. But this is not considered as ideal, and there are many loopholes in this Bologna criteria. And for this came the Poseidon criteria. This Poseidon criteria is for low prognosis groups, and this is very interesting because it has clear-cut demarcation of various groups. Poseidon group 1 includes young patients, where the patients are young, their age is less than 35, and there is a surprise response or unexpected poor response. The patient has got a good AMH, good AFC, but still the oocyte retrieved are low in number. If they are less than 4, it is called as 1A group, and if they are 4 to 9, it is called as subgroup 1B. Similarly, in Poseidon group 2, the patient is more than 35 years, but the AMH levels are normal, AFC is now normal, but still there is unexpected poor response. And includes 2A, where the oocytes are less than 4, and 2B, where the oocytes are 4 to 9. The most important group is Poseidon group 3. And we are actually focusing on this group. Why we are focusing on this group? Because this is the patient who is young, whose age is less than 35 years, but they are having poor ovarian reserve. And pre-stimulation parameters are AFC less than 5 and AMH less than 1.2. And this is the group where the treatment modalities are very important, and you have to decide about the treatment in these patients. And then there is Poseidon group 4, where the patients are old and they are classical cases of diminished ovarian reserve, where AFC is low, AMH is low, and age is also more than 35. Now, whenever we are discussing these groups, group 3 is something which we have to focus, because these are the groups which can be actually treated by many conditions or many treatment plans. So before you start treating the patient, you have to have the ovarian reserve testing, and you must assess and predict the response to ovarian stimulation, which is done by ovarian reserve testing. As we have seen, Poseidon criteria, response to stimulation cannot be predicted even in young patients. Sometimes you may get surprise low response in young patients also. Therefore, what is important is, apart from age, BMI, and the infertility factor, you have to look for the anther follicles. And this is done with the help of ultrasound. And I think ultrasound is something which is most important. It plays a crucial role. And nowadays, we have 4G Voluson machines with us at our hospital. And with the help of this Sono AVC, which is a wonderful application, we can actually count the anther follicles in the ovary, and you know that how is the patient going to respond to the stimulation. The basal hormonal assays are FSH, E2, and AMH level. And out of this, AMH is becoming more and more reliable. They are becoming so reliable that now the question is, are day 2 hormonal assays losing its significance? And the answer is probably yes. FSH and E2 and LH are losing their significance. Why it is so? Because there are some advantages of this day 2 testing. They are cheap and time tested, but there are many disadvantages. They are influenced by external factors, and the accuracy in prediction is less. So suppose you just look at the image. you will find that you can do AMH at any time during the menstrual cycle because there is no intercycle and cycle fluctuation. And the effect of OC pills and GnRH analogs or any other drugs is seen on FSH, but it is not seen on AMH. So AMH levels are not influenced by all these investigation of all these drugs like OC pills or gonadotropins, and that is the point which is important for and which is in favor of AMH. So there is rise of AMH, and it is becoming more and more reliable day by day, and therefore nowadays we have almost stopped doing FSH, but we completely rely on AMH for the treatment plan or for deciding the treatment plan. So grossly, you can say that AMH less than 1.1 is low, 1.1 is 3.5 is considered as normal, and more than 3.5 is considered as high AMH level. And again, this is the at a glance chart which gives you idea about various ovarian reserve testing and their importance. And you all can take a screenshot of this chart as well, because this chart is going to give you idea about so many things. Like suppose you look at this prediction of poor response, you'll find that AMH is the best, and even AFC is really good for prediction of poor response. Prediction of hyper response, AMH is the best because it gives you idea AMH is high, that means patient is having PCO. Similarly, AFC is also the best for this. Intercycle and intracycle variability are not seen in AMH. The most important thing is blinded to operator. The same one person can do ultrasound so well because he has been doing this ultrasound since last so many years, but a newcomer may not be able to do ultrasound properly, and then he or she may miss some important findings. And so therefore, if you look at all these things, the cheapness is something which is there with age. Age is, I think, something which is most important, and where you can get idea about so many things, provided patient gives or tells you the proper and the correct age. I think that is also important. So this is the chart which you all should know, and from all these parameters you come to the conclusion that AMH and AFC along with age are the three things which are crucial for ovarian reserve testing. Now counseling part is something which is important, and late marriage and late childbearing is becoming new normal. The problem is with the understanding of possibility of diminished ovarian reserve. Even with advanced age and low MH, patients are not willing to accept that they are having problem, and then we need to handle them tactfully and carefully. Because if you say that you cannot get a baby, or you cannot conceive, then they feel offended. So you have to you have to be very careful. We need to give them some time to think about it. Like you can, during that period, you can do time intercourse or IUI for 2 cycles, and then you can go for IVF. So it's a balancing act, and then your counseling skill is something which can do wonders and help couple to have their own babies. So counseling plays a crucial role. You have to give time, talk to them, and also listen to them. What is their idea? If they are not aware that their AMH is low and they are not able to conceive, then it is your duty to get their opinion also, and what they wish to do, what is their idea, and then slowly and steadily you can counsel them regarding IVF as the last option. Now whenever the patient comes with low AMH, they'll say AMH कम है तो क्या हुआ, मुझे कुछ दवा दीजिए और उस दवाई से मेरा AMH बढ़ जाएगा. So it is so simple, and then you have to tell that it is not that easy. It is not, you may not be able to increase to a great extent, but there are some drugs which are available, and all these are the adjuvants, and you can definitely try adjuvants, and one of the adjuvants is DHA. So what is DHA? DHA is a product of adrenal and ovarian steroidogenesis. It is a mild androgen which is converted to testosterone estrogen. Norbert Drescher and Kassan, they have studied extensively on DHA, and the studies have shown that there is a significant improvement in ovarian performance. Now this DHA is something which acts at this level, the level of pre-antral and early antral follicles, and therefore it is acts synergistically with FSH, and therefore you have to give DHA almost 6 weeks to 12 weeks prior to starting the treatment. It improves the oocyte yield, it improves the embryo number, it increases the chances of pregnancy in IVF, and even it increases the chances of spontaneous pregnancies, and it reduces the miscarriage rates and chances of aneuploidy as well. Duration of DHA minimum 6 weeks, ideally for 3 months. 25 milligram TDS is the dose, but nowadays 75 milligram tablets are also available. Start at least 6 weeks before IUI or IVF, and give till second pregnancy test is positive. But remember friends, DHA is neither a panacea nor a miracle drug. DHA is just even in Western countries, it is available as a over-the-counter drug, and it is just a drug which may help you in improving the ovarian performance. Another drug is testosterone gel. It increases intrafollicular androgen and increases the number of FSH receptors in the cells, and growth of follicle is improved by this, and there is a better response to gonadotropins. It is available as a transdermal application of gel. It is available as 25 milligram or 12.5 milligram dosage. You can give it on 15 days or 21 days prior to stimulation. Usually we give this gel to all our diminished ovarian reserve patients 15 days prior to the day of stimulation, and continue it till the day of HCG. There are many RCTs and many studies, but more studies are required as far as testosterone is concerned. Another drug is growth hormone. There is a great deal of controversy about this drug. It is available since 1990s. It is said that there are growth factors like IGF and IGF-BP, which are responsible for follicular development. And IGF-1 is growth hormone dependent and is involved in potentiating the effect of FSH. So growth hormone works in this way, and you can give growth hormone 8 international units per day. You can start it from day 7 up to the day of HCG, or you can start it for a long period also. You can start it from day 21 of the previous cycle and give till HCG day. Usually, if at all we give growth hormone to the patients, we give this growth hormone from the day of stimulation and give it for 15 days. A very interesting meta-analysis by Carrier et al. Says that they evaluated 22 RCTs and they tried to find out 50 interventions which can help in stimulation of the ovaries in diminished ovarian reserve. And out of all these 15 interventions, they found that human growth hormone injections and day 2 intervention or day 2 embryo transfer are the only 2 interventions which were having beneficial effect. So this is really interesting. But I think this study should be taken with a pinch of salt, because you can have many other factors also which help in improving the ovarian performance. And the cost factor, as far as growth hormone is concerned, cost factor is also equally important. It is quite a costly drug. So we have, since growth hormone is costly, we have Gariboka growth hormone, and that is pyridostigmine. Pyridostigmine actually acts on AC inhibitors, and it helps in increasing the growth hormone secretion. The dosage is 60 milligram BD. It is available in the form of tablets, and it has to be given from day of ovulation stimulation till HCG. No much support in favor of pyridostigmine, but we regularly give pyridostigmine in many of our patients, and we find that we get good results with pyridostigmine as well. CoQ and antioxidants also have got a role to play. As we give antioxidants in male infertility, we can also give this in diminished ovarian reserves. After these tablets and drugs which are available, there is something called as ovarian PRP, something which we all can do in our day-to-day practice. PRP actually enhances the development of primordial and primary preantral follicles. It assists in tissue regeneration. Most of the studies, they inject PRP through pouch of Douglas or POD under TVS guidance using ovum pickup needle. This is something which is very easy to do. Technically, it is easy. But if you are not planning IVF, or if you are doing IUI and you have to do laparoscopy, you can do ovarian rejuvenation through laparoscopy as well. And that is what we do in many of our patients. If the patient is for IUI, or if the patient is for simple treatment and the AMH is low, we inject PRP through laparoscopy. And initial studies have shown promising results. This is how we do it. We just put the laparoscope, and with the help of a needle, we inject PRP into the ovaries. After injecting the PRP into the ovaries, we do AMH after 1 month and repeat AMH after 3 months, and then we see the results. This is the treatment which we do along with the ultrasound guided PRP injection in the ovaries. Now, this is the latest study on PRP, which shows PRP is going to help in improving the ovarian performance. In April 2020, where they are trying to find out the effect of PRP in patients of premature ovarian failure. Stem cell is something which is a novel approach, but it is still in experimental stage. Many people have started doing it. Dr. Sunita Tanurkar has presented paper on this stem cell, and many people in India have also started doing this stem cell injection. PRP is easy to do. Stem cell therapy is a little bit difficult, but it will give you better result as per initial studies. Now, this is a ROSE trial. This ROSE trial is the latest trial of May 2020, where they have tried bone marrow stem cells and they have injected this stem cell through laparoscopy into the ovaries. So similarly, the way we inject PRP, they have injected stem cells in the ovaries, and this trial is giving good results. Now comes the approach towards the patient of diminished ovarian reserve. As we have already discussed, diminished ovarian reserve may come as a shock to many patients. It takes time to get adjusted to the reality, and for this fact to sink that you may have to give couple some time and you may give couple some time to think. And the good news is spontaneous ovulation and spontaneous conception is something which is known not only in diminished ovarian reserve but even in POI. So if you give some time, then maybe patients can conceive, but you cannot give more time to them because you have to have a balancing act. Now, what about IUI? Can we do IUI in patients with DOR? The answer is yes. IUI is worth trying, and in DOR, IUI is possible, but it gives low pregnancy rate. As it is, IUI gives low pregnancy rate, and in DOR it will still give more the low results. But you can try IUI in 2 to 3 cycles. It is worth trying, especially in Poseidon group 3 patients, where the patients are actually young patients with age less than 35 years, but AMH and AFC is low. Also, the duration of marriage is important. If the duration of marriage is less, then IUI can work. So there are many studies which says that young patients with diminished ovarian reserve, IUI can do wonders and can work. And the live birth rate is comparable with other factors, and IUI can be done in such patients. But you have to stop somewhere. You cannot go on doing IUI for months together or for years together. That is what many people do. 10 cycles of IUI, 15 cycles of IUI. You cannot do more than 3 cycles in patients of diminished ovarian reserve, ideally 2 to 3 cycles. Now, what is the protocol for IUI? The conventional protocol can be tried, but if you don't have much time, and you have, this is something which is say a last chance in IUI, then you have to give your best. You have to perform best. And for performing best, what you can do is you can start with antagonist cycle and give gonadotropins and do IUI just like IVF. You may get good results. So this is worth trying. Antagonist cycle with gonadotropins and IUI is something which is worth trying. Now comes the last part, and that is IVF. And in IVF, it should not be too early. It should not be too late. We are not doing it early. We are already late. So we should remember that you should not be too late. And you have to start the treatment. Now, when you start the treatment, you give gonadotropins to the patients. These gonadotropins are given by a natural tendency in a very high dose. It's a natural human tendency कि भाई ओवरीज काम नहीं कर रही है तो उसको बहुत ज्यादा gonadotropins के dose दो. So people give 450, even 600 IU of gonadotropins in such patients, but it has been found by most of the RCTs that there is no benefit if you give HMG more than 300 IU. So remember, friends, do not give high dose of HMG. It is of no use. Give HMG not more than 300 because it does not work. Now, some people, they give HMG in a low dose, say 225, and then after 5 days, they suddenly start feeling that there is no response and they increase the dose. Now, this is the study which says that there is no point in increasing the dose after 5 days. If you make it 225 to 600, suddenly if you shoot your dose, then there is no effect of doubling of dose. There is no effect, and it is of no use. So you should not do such thing. You should continue with the same dose and have some patience. Now, whenever we give treatment to the patients of IVF, we have to do down regulation, and down regulation is done with the help of agonist or antagonist. Now, agonists, they are actually good, and initially 10 years back, we used to do only agonist protocols. This is a long protocol which gives good cohort, more top quality embryos, and a good endometrium. But there are some points which are against agonist protocol. The agonist actually suppresses the ovaries, therefore there is ovarian hyperresponse. More cyst formation is there, and you require more injections. But of late, agonist protocol is again becoming popular because of 2 reasons. One is the good cohort and good top quality embryos, and also good endometrium. And therefore, it is said that in diminished ovarian reserve patients, especially Poseidon group 3 patients, where the patients are young, but these young patients are having problem of diminished ovarian reserve. In these patients, if you give agonist protocol, then you may get good embryo quality, less ET cancellation rates, and high implantation rates, and high live birth rates. And therefore, Poseidon group 3 criteria category is the category where this agonist protocol works very well. So this is the classical agonist protocol where you start from day 21 of the previous cycle and continue agonist up to the day of HCG. So this is a very classical standard protocol of what is called as agonist protocol. Also, you can give microflare protocol of agonist where you start agonist late on day -2 or -1 and continue till HCG. Or you can give short agonist protocol where the flare-up effect of agonist is used, and that is something which can be tried. Now comes the antagonist. And as far as antagonist is concerned, antagonists are actually now it's becoming a standard treatment, and it completely blocks the GNRH receptors and gives good response. And also you can use CC and letrozole and other drugs along with antagonist. So this is a very classical antagonist protocol where you start from day 6, day 7, or day 8. You can make it flexible when the follicle, leading follicle becomes 14 millimeter in size, and then continue antagonist till the HCG trigger. Now there are some alternate approach where you can actually use antagonist in previous cycle. It is said that in diminished ovarian reserve, the cycles are short cycles. And because of short cycle, what happens that the recruitment phase is also short. To lengthen the recruitment phase and to get more rescue of more follicles, you can give antagonist in the previous cycle 2 times on day 5 and also on day 9. 3 milligram cetrorelix can be given. And this is a protocol which is also accepted because it gives you good results. And you can combine agonist and antagonist. Microflare agonist protocol followed by antagonist protocol is something which gives you benefits of both. So the best of both the worlds you can get with agonist antagonist combination. And then there is something called as ultra short MINIFLARE protocol. This is the protocol where the patient received agonist first and then patient received antagonist, and this is how this protocol works. Now there is something called as International Society for Mild Approaches in Assisted Reproduction, or ISMAR. And this International Society ISMAR has given various terminologies for natural cycle and modified natural cycle. This natural cycle and modified natural cycle is something which is actually tried by many people and many clinicians in patients with diminished ovarian reserve. In natural cycle, there is absolutely no medication. You are not supposed to give anything to the patients and let the follicle grow and let the follicle naturally rupture, and before rupture you do the pickup. But it is said that this is not good because there are high cancellation rates. But another protocol is modified natural cycle protocol, which is actually a soft protocol. You require less injections and you get good results. Here they have done this Kolibansky case et al. Have tried this as a last resort, and what they did, they gave recombinant FSH 100 international unit, and antagonists were started at 14 millimeter of follicle, and HCG was given early, that is at 16 millimeter. And HCG, if you give early, you get better result. That is what they say. So a very low dose of gonadotropins and antagonists are given. So this is what is a mild stimulation protocol, where you start with letrozole and CC combination and then give only 3 doses of gonadotropins and then do ovum pickup. Another mild stimulation protocol is this protocol where you give CC for 5 days followed by 1, 2, 3, 4, 5 injections of gonadotropins, 2 injections of antagonist, and then do the ovum pickup. So minimum injections is the key of this treatment of diminished ovarian reserve. And there is called as what is called as CATO protocol. And in this CATO protocol, 10 days of CC is given and HMG is given only for 3 days, and then pickup is done. So all these protocols, they are actually soft protocols and they are mild protocols and they work very well in diminished ovarian reserve. This is a modified natural protocol, also called as late start protocol, where you start gonadotropins on day 11 and then you do ovum pickup. So all these protocols are definitely going to help you in diminished ovarian reserve. Now something called as LH or role of LH. If you are giving gonadotropins to the patient for stimulation, then you have FSH, you have recombinant FSH, you have recombinant LH, and you have HMG. Now this REC LH is said to play an important role in the second half of the stimulation, because folliculogenesis and steroidogenesis depends on the LH threshold, and low dose LH is essential for steroidogenesis. This LH will give you robust response. And if age is more than 35, the benefit of LH supplementation is more. Along with LH, you can also give HMG. Actually, HMG is nothing but LH, so it is a cheap alternative to LH. Some people have tried OC pills pre-treatment, and some people have tried luteal phase manipulation with E2. You can give estradiol in the luteal phase for 7 days, and this will give you a good response in diminished ovarian reserve. So this is the luteal E2 antagonist protocol, where E2 is given for 7 days before starting the stimulation. I have discussed everything, and this is the summary of all the things. This is a care protocol, something which is a summary of what we have discussed till now. Care protocol, you can start with OC pills. You can give DHE to the patient for 3 months. You can give estradiol for the last 1 week and prepare the patient for the cycle, and then start the stimulation. You start stimulation with growth hormone.
And worst was,
Hello.
Chaitanya, is another device active? No,
No,
I
not
muted. There
mine,
were a few
not
people who
mine.
were unmuted. Go ahead, go ahead.
Yeah. Okay. So this is the actual stimulation cycle of care protocol, where you give gonadotropins and growth hormone to start with. Then you give low dose aspirin to the patient for improve the blood supply. Then you start antagonist to the patient on day 6 or day 7 or day 8. Then you give HCG as a trigger, and then you continue with the progesterone support. And here the dose of gonadotropins is low, and that is 300 to 450 IU. So you don't give high dose of gonadotropins. Now there are some recent strategies which are also important, that is called as double stimulation protocol, where you know that there is a follicular recruitment wave there. You take the advantage of this wave and do stimulation 2 times in 1 cycle. So you get more opportunities for retrieving oocytes in poor responder patients. Now this is something which is very popular in cancer patients, but you can try this in DOR patients also. This is called a Shanghai protocol. Shanghai protocol is actually a dual stimulation protocol, where you start with the stimulation on day 2 or day 3 of the menses, complete the stimulation, do ovum pickup, give 1 day break and start stimulation again. And the second wave of folliculogenesis is taken care of, and you get more follicles and you get more oocytes, and 2 times in 1 cycle you are doing ovum pickup. So that is called as Shanghai double stimulation protocol. This is one more protocol called as duostim protocol, where you give 11 days or 12 days of gonadotropins, do ovum pickup, give 3 days of gap, and again start gonadotropins and again do ovum pickup. And these are the protocols which are becoming very popular in cancer patients, where you don't have time and you want more and more oocytes in short time, and also in patients with diminished ovarian reserve, where you want to get more oocytes and you want to get results as early as possible. If you just look at the choice of protocols, you'll find that antagonist protocols are doing well. Agonist protocol are also equally well, but the natural cycle protocol are something which should not be tried because it gives only 3.5% success rate. But others are something which you can, it is worth trying. There is something called as COFACI, and this COFACI is also becoming popular these days, though not very popular, but some people are doing this COFACI to get good results. Now, what they do, what is this COFACI? COFACI is co-transfer of fresh and collected cryopreserved embryos. So they do 1 cycle of IVF, they collect the oocytes, they form the embryos, they freeze the embryos, and then they do another cycle of stimulation. They do fresh embryos, and they, along with the fresh embryos, they transfer the frozen embryos. So that is called as COFACI. This is something which is tried by many people, and people are also getting good results out of this. Now, when to give the trigger? Trigger should be given early. When the patient is having DOR, you can give it at 16 millimeter, and retrieval should also be done early at 34 hours, because it takes care of premature luteation of follicles in older or DOR patients. So therefore, you do give HCG at 16 millimeter and do retrieval at 34 hours. After the trigger, that is when the ovum pickup is done. After ovum pickup, you have to give corpus luteum support. And this corpus luteum support is important, especially in patients with diminished ovarian reserve, And this can be provided by a single dose of leupride 0.5 milligram subcutaneous or triptorelin 0.1 subcutaneously on day 6 of ovum pickup. This is important. The 6th day of ovum pickup is the day where you require corpus luteum support. And all the more you require support in patients with diminished ovarian reserve because they are having corpus luteum which is not very active or which is not very robust. And there are 5 studies on this till now. Out of this, almost 3 studies they have said that there is a benefit of giving corpus luteal support in the form of leupride injection or triptorelin injection on day 6 of ovum pickup. Remember, friends, this is something which we do in our day-to-day practice, and we are getting good support and good results with the extra support which we give in the luteal phase. Embryo pulling and embryo banking is something which is becoming more and more popular nowadays. It is because of the improvement in the freezing techniques. Because of very good freezing techniques, in fact, the situation nowadays is such that frozen cycles are giving better results than the fresh cycle. And therefore, you can actually pool the embryos. You can do 2-3 cycles of ovum pickup, collect the embryos, collect the oocytes, get more embryos, and all these embryos are then later on transferred. So you are creating a similar situation as a normal responder. So if you have 15 embryos available with you, you can select the best embryo and you get good results. So that is the advantage of embryo pooling and embryo banking. Ovarian cryotissue preservation is something which is becoming popular nowadays, especially in cancer patients and also in patients with diminished ovarian reserve. And there is a lot of work done by Anderson et al., where they have done more than 500 patients and they have got 100% results in regaining ovarian function. So this is really interesting that ovarian tissue cryopreservation is also becoming more and more popular these days. As far as oocyte freezing and embryo freezing is concerned, if the patient is married, but if the patient is not planning pregnancy, then you can go for embryo cryopreservation. And if the patient is young, she is unmarried, then you can go for oocyte cryopreservation. These are the options which are available. And I think IVF donor program is the last but not the least option. It is the only treatment option which is established because it gives the best results and the maximum success rate is with the donor program. And therefore, you can give this option to the patient. And now that we have discussed everything, I'll take just 5 minutes. This is the last part of my oration, where Jate I am going to discuss a case of Monica. This Monica is a classical case of diminished ovarian reserve. And see the history of Monica. She is 38-year-old. She is teacher by profession. She's from a middle class background, but she is trying hard to conceive. She is married since 12 years and she is giving history of 2 failed IVF cycles. She has come to you. She came to the hospital with 2 IVF failures and now she is for the 3rd IVF cycle. On history, there was only one significant history, and that was 10 years back. Her laparoscopy was done by a general surgeon, and on inspection, they found that the ovaries are big and they drilled the ovaries like this. You can see this picture of a charred ovary. And this is also one take-home message which I would like to give you all, that always respect ovaries and see to it that even if somebody is doing is doing drilling, ovarian drilling, you have to talk and tell them that ovarian drilling should be done carefully and only in selected population of patients where they are really having very high AMH levels and are having overt PCOS. Otherwise, you should actually restrain from drilling the ovaries and burning the ovaries because this is going to reduce her ovarian reserve. Now, initially, her AMH was 0.9. Now her AMH is 0.7. So her AMH is going down. Her first IVF cycle was done 4 years back. Her AMH was 2. And their FSH was given 375. Second cycle, AMH was 0.9. HMG 600 was given. Endometrium was good all the time. And now she is for 3rd cycle. Now, how do we counsel for this patient's checklist? She is not willing for donor program. This is a changing trend. Initially, male partners were not willing for donor semen. Nowadays, girls are becoming more adamant and they are just not ready for donor program. And you have to respect their sentiments. You have to have empathy for them. You have to think that how they must be feeling. Because if you tell them that your ovaries are not working and you will not get to go for donor eggs, they are shattered. They are shattered, and that is the reason why you have to see to it that you have to respect their sentiments. Then we have options which are available. We discuss about stem cell therapy. She said, no, I cannot afford stem cell therapy. but she was ready for PRP. We did her transvaginal ovarian PRP. We started on DHEA and testosterone gel. Growth hormone was not given because again it is costly. Now the dose which she received initially was 600 IU. So we decided to change the dose. We thought that we will do embryo banking, but she was not ready for embryo banking. And we also give her option of PGTA because she may have aneuploidy, but she said, no, I cannot afford this. But we did her laser hatching because laser hatching is something which can be done. So we'll discuss one by one. Stimulation dose, initially 600 IU. Is it a right dose? I think this is not a right dose. As we have already discussed, soft protocols are better protocols, and therefore you have to start with a low dose. Keep our minds open because minds are like pens. They work only when they are open. Therefore, you have to keep your mind open and think about the right dose of this patient. So what is the right dose? Maybe we started with HMG 300 and letrozole combination, and we put her on antagonist because she was already 38. We got 4 follicles. We found that there were 4 oocytes on ovum pickup. Out of these 4 oocytes, 3 were M2. So it's like a pyramid. If you get 10, if you see 10 follicles, you will get 8 oocytes. Out of 8 oocytes, 6 will be M2, and you will get 3 embryos. So ultimately, we were lucky to get 3 embryos. Out of these, 2 were grade 1. So we decided to transfer them early. So we decided to go for day 3 transfer. Why day 3 transfer? Because it is said that if you do not have good number of embryos, then you may go for cleavage stage transfer and not the blastocyst transfer. So we decided to go for day 3 transfer. Now, how many embryos to transfer? Now we had only 3 embryos available, so we decided to transfer all the 3 embryos. If it's a blastocyst, we will transfer 2 embryos. If it's a cleavage stage, we will transfer 3 embryos. But people say that you can transfer 4 embryos if age is more than 40. But I think we should stop doing this. In fact, I am of the opinion that we should stop transferring 3 embryos. We should prefer to transfer single embryo in blastocyst case and 2 embryos in cleavage stage case. That is what we should do. Now, Monica is 38 years. So there is a possibility of embryo genetics and problem with aneuploidy, and therefore you can actually offer her PGTA. It is said that PGTA is something which can be tried in patients where the age is more. But again, the cost factor is something which is prohibitive. Then laser hatching. Laser hatching is something which is done in patients of recurrent implantation failures, patients of thick zona, patient where the age is more than 35 years, and patient where there is a diminished ovarian reserve. In all these factors, Monica is the fit case, and therefore we decided to do her laser hatching, and she got good result because of laser hatching. And after day 3 embryo transfer, anything else, we decided to give her corpus luteum support in the form of leupride 0.5 milligrams subcutaneously, which was given on the 6th day of ovum pickup, as we have already discussed. And it is said that all is well that ends well. Monica is now happy. She is having a baby. She delivered a baby girl few days back, and this is the success story. And this is success story which we all should actually look forward for, and we all should try for these success stories. Now the question is, why do we Indians suffer the most, be it diminished ovarian reserve or premature ovarian insufficiency? Unfortunately, it is said that ethnicity plays an important role in this problem, and Asians are more prone to infertility because of ovarian insufficiency. So Asians have this problem of ovarian insufficiency, and this is the study, or there was a study regarding ethnicity and diminished ovarian reserve, where this is the study by Nova IVF, where they tried to compare the ovarian age of Indian woman and Spanish woman. And what they found is that ovarian age of Indian woman is 6 years ahead of Spanish woman, and therefore their ovarian age is becoming a great problem and a great hurdle in conception. Now this is an eye opener, and so friends, remember, time is ticking, and you cannot actually wait, and you cannot wait beyond 35. 35 is the limit, and the patients are not going to conceive, or they are going to have difficulty in conception because of diminished ovarian reserve, which is so commonly seen in Indians. And you cannot compare yourself with Western countries, because Western countries, they have different story. Now, before I sign off, I'll tell you some shocking facts which I have seen in my day-to-day practice. The changing trends which we witnessed at Omega IVF Clinic. Last week, we recruited a 40-year young girl. She's 40 years. She's a young girl. She's seeking a match. She's seeking a match. She for oocyte cryopreservation, she is yet to get her sapno ka Rajkumar, and she is yet to find a match. Once she finds a match, she will marry and she'll have her own children. But for that, she wants to have her oocytes cryopreserved. There is one more patient who is coming to me with marital conflicts, and she is not yet divorced. She is not yet divorced. Her husband is she is staying with husband, but she says that I don't want baby now. I want my oocytes to be cryopreserved. We took a opinion of medical legal expert, and our medical legal expert said that you can go ahead and you can actually do this. Now, more and more patients are coming with DOR at a very young age. Last year at Omega IVF Clinic, we had 4 unmarried girls with diminished ovarianism. They came with scanty menstruation and short cycles. Their AMH were around zero point 0.4 to 1.1, and their age was around 22 to 25 years. One of the patient was a blogger, travel writer, and a photographer. She said, I cannot think of marriage. I don't want marriage is not on my cards and not on cards, and I cannot think of marriage now. So we offered her freezing program, and marriage was on cards in 2 girls, while one girl she was counseled for early marriage, and all were told to try for conception immediately after marriage. So this is something which is happening nowadays, that the patients they came with short cycles or amenorrhea, you do their AMH and you find that their AMH is shockingly low. It is 1.1, sometimes it is 0.6, 0.7, and then you don't have much time and you just cannot do anything in such situation. So the philosophy of life, my friends, we all know, is karmanye vadika raste ma phaleshu kadachana. Karma karte raho, phal ki asha mat karo. And same is the philosophy of infertility treatment. And I am so thankful to all of you for having me as an orator. Thank you, NOGS. Thank you, Vaidehi, Rajasi. Thank you, Dr. Vijay and Manisha Tamaskar, for giving me this opportunity to talk in front of this August gathering. Thank you very much. Thank you.
Thank you, Dr. Chaitanya. I think when it comes to three things in public speaking, one is to get into your subject, which you have already done before coming to for today's oration. Then to get your subject into yourself, which you are already master for that, and to get your subject into the heart of your audience. I think that's also very, very important, and that's where your orator skill comes, Chaitanya. I think I
Thank you,
congratulate
Kundan.
you for such an excellent oration. Friends, we were discussing about reducing the fertility factors in India. And I think decline in fertility means there is definitely increase in the prevalence of the causes of infertility. I think that goes hand in hand. And we are seeing that. I think what was Indian scenario 40 years back and now, there is a higher education, there is a increased mobility, there are late marriages, financially independent women, and overall prosperity. I think all these are the important factors which are actually reducing fertility in India. And in many clinical scenarios, this reduced fertility is irreversible, and we just cannot do anything. As you mentioned about diminished ovarian reserve and so many other things. So I think ART is the very important science which comes for help in such scenario when we cannot enhance the fertility by any other means. So, Dr. Chaitanya, I think you are a dynamic orator and you have given us very intelligently the broad view about how to improve fertility, maybe before ART and also during ART. And it was really an honor to chair this session of Dr. Kumud Tamaskar Oration with you as a orator deliberating on such an important topic.
Thank you,
On my
Kundan.
behalf and my co-chairperson, Dr. Sadhna, behalf of her, I thank you, Dr. Vaidehi, to invite us to chair this session, such an important oration and prestigious oration for all of us. So, Chaitanya, once again, thank you very much. I request Dr. Sadhna to give one line of comment on it, and then
Thank you,
maybe we
Kundan.
can hand over to the host. Yeah.
Sadhna, unmute.
Yeah, it was indeed a pleasure listening to you. And declining fertility is really a great problem and a big challenge today. 25 years down the lane, we have been noticing it that women are switching over to their obstetric career after their professional careers. They're approaching us late, and by the time they approach us, they really have diminished ovarian reserve. It is a challenge stimulating this women getting good quality oocytes and good quality embryos So the lesson at the end of the day, you know, the take home messages to all the girls, to the all young girls, female population, is get married early, have a baby early, you know. Oocyte freezing, this and that is all there, you know, but this should be the message given to the generation of today. And it was indeed a great pleasure to be a part of this academics. Thank you once again.
Thank you, Dr. Sadhana. Thank you.
Yeah. So, Chaitanya, I have really no words to thank you for this outstanding oration. Swati, can you please share screen? That is Swati. Yeah. Yeah. So, on behalf of Nagpur Obstetrics and Gynecological Society, along with the chairpersons today, Dr. Kundan Ningre sir and Dr. Sadhana Patwardhan, and family of Dr. Tamaskar ma'am, it gives me immense pleasure and honor. I present this citation to Dr. Chaitanya Shembekar for his immense contribution in the field of infertility and the wonderful deliberation of Dr. Kumud Tamaskar oration on declining fertility, today's reality. And NOGS deeply appreciates his academic talent and original research work through this oration, dated 5th February 2021. Thank you so much, Chaitanya. It was indeed our honor to host this oration. Thank you so much.
Thank you so much. Thank you.
On this occasion, I also wish to invite Dr. Vijay Tamaskar, sir, son of Dr. Kumud Tamaskar, and daughter-in-law, Dr. Manisha, to say a few words. I would invite them, please. You can unmute, sir. I also want to welcome Dr. Shailesh Puntambekar, sir. He has joined us a few minutes back. Welcome, sir.
Thank you.
Shailesh sir, welcome.
Thank you. Thank you. Thank you, Chaitanya.
Just give us 2 minutes only, sir.
Yeah, yeah.
Yes, Tamaskar, sir. तुम्ही unmute करू शकता.
Yeah. Thank you very much, Chaitanya. And thank you to Dr. Vaidehi Marathe.
Dr. Manisha, तुम्ही बहुतेक 2 device मधनं log in केला. एक switch off करा तर बरं. Yeah.
Thank you very much to all of you, Vaidehi Marathe, then Dr. Ingre, Dr. Chaitanya Shembekar for this oration. It was really a very informative talk. And I'm very much grateful to you on behalf of the Tamaskar family to arrange for this oration in spite of having this COVID problem all throughout the world. To say a little bit more about my mother was a very senior person from the first batch of Government Medical College, Nagpur, 1948-47. And she was the first to start the laparoscopy in the early 70s and started her IVF in Nagpur when the medias were not available easily. We used to prepare our own medias in the house. We had a triple distillation water plant in the house. We used to purchase and do all those things, and then we started. We used to get up in the middle of the night to do the ovum pickup because all these protocols were not there. She had been to Australia, she had been to UK, to all the big shots who started the IVF. So it was really a big thing. Now it has come to such a thing that there is a lot of good protocols available to have the good results. So that is how we started the IVF in Nagpur. And now my wife is also doing the IVF. My niece and nephews are also doing. So we are very much now into this particular IVF thing. So I am very much thankful that you gave this oration, Chaitanya, Dr. Chaitanya. And thank you, Dr. Vaidehi, Dr. Ingre, Dr. Sadhana Patwardhan, Dr. Sen Gupta, and Dr. Sarda for introducing my mother. Thank you very much.
Thanks, Vaidehi. Thanks, Chaitanya. It was wonderful.
Thank you so much. Thanks. Yeah. So that brings us to the end of session 1. Over to you, Swati.
Thank you, ma'am. Thank you very much. First of all, thank you very much, Chaitanya Shembekar sir, for such a wonderful oration. It was truly, as always, it was wonderful listening to you, sir. Thank you so much. I also thank our chairpersons, Dr. Sadhana Patwardhan, madam, and Dr. Ingre sir for your insights and concluding remarks. And now it's the time to move out to our today's second session by Dr. Shailesh Puntambekar sir. On refining laparoscopy in gynecological surgeries. And to start this session, I would like to invite our chairpersons for today. Our first chairperson is Dr. Sindhu Bhute ma'am, a very senior gynecologist and who has been working in this field since last 50 years, and presently she is working as professor